Welcome to JAT Chat, presented by the Journal of Athletic Training, the official journal of the National Athletic Trainers Association. I'm Dr. Kara Radzak at the University of Nevada, Las Vegas, and host of JAT Chat. The purpose of today's event is to provide more information for athletic trainers and other allied healthcare professionals to ask questions and discuss the manuscript entitled Closed Reduction Techniques for Glenohumeral, Patellofemoral, and Interphalangeal Joint Dislocations, which is currently available on the website as an online first publication. Today, I'm joined by two of the manuscript's co-authors, Dr. Cynthia Wright from Whitworth University in Spokane, Washington, and Dr. Barbara Brandon from the University of Washington School of Medicine. At this point in time, I would like to introduce Cynthia and Barb, and thank you so much for taking this time to speak with me today.
Thank you for having us. It's a pleasure.
Yes, thank you.
The first thing that I want to ask is, Cynthia, tell us a little bit more about yourself and how this project came to be.
Well, I am a program director at Whitworth University, as well as a clinical athletic trainer. And athletic training has really evolved over time, both in our educational competencies. So obviously in the new KD 2020 standards, it includes joint reductions. And as we were preparing to transition to those new standards, I started having a lot of conversations with our team physicians, Dr. Brandon, who is here, and then Dr. Ed Reisman, who was unable to join us today, about what that would look like in our program. And out of those conversations and the research involved, we started thinking about making some, I did a presentation at our district meeting, and then started thinking this was something we really wanted to share with others to help them in their journey towards doing this for athletic trainers.
Thank you. And Barb, give us a little bit more information about your clinical background, please.
So I have been the Associate Program Director for a Sports Medicine Fellowship in Spokane, Washington, and just recently transitioned to working with a community federally funded clinic where I'm working with the underserved. And during my time as the Associate Program Director, I was a team physician with Whitworth University, worked with the Spokane Chiefs, which is part of a hockey team league that is here in town, and also was the team physician for the Spokane Indians, which is part of the minor league baseball teams.
Nice. So give us a little bit of more information of who's the target audience for this manuscript. Why did y'all decide to put it out there?
The target audience is really athletic trainers. As we started looking into this topic, it was very clear and apparent there's a lot of literature out there, but none of it was targeted specifically for athletic trainers in our unique scope of practice. And so some of the techniques we talk about are also described elsewhere in the literature. In fact, all of them are. But what we tried to make unique about this was that anything that you would read in the other literature that would be like, well, an athletic trainer couldn't do that or shouldn't or would do it differently, we tried to change that up, including some techniques that just don't really apply to on the court or on the field settings. So we really tried to target it into that athletic training. It is more focused towards athletic trainers in traditional settings, athletic settings, but it could be applied to any athletic trainer.
Thank you. And so what are some considerations for athletic trainers prior to being comfortable with developing a closed reduction technique practice?
Some of the considerations, kind of the prerequisites, if you will, are to look at your own state practice act, make sure that joint reductions are permitted in your state. Just because they're part of the new KD 2020 standards does not necessarily mean that they're part of your state practice act. So in addition to looking at your state practice act, looking at your liability insurance, making sure it's covered in your liability insurance, and then also talking to your supervising physician. It has to be a conversation. They have to be willing to give you standing orders. And so until you're there, knowledge of the techniques isn't going to help you until you're able to apply them. And those are some of the kind of prerequisites.
Thank you. Barb, can you give a little bit more of insight from the physician side of things? If an athletic trainer is coming to you requesting standing orders, how can that conversation go really positively?
Well, in the article, we actually sat down and published, it's part of the table 1 in the article about a checklist that is available. That is a great way to start the conversation with your supervising provider. because it kind of touches on the areas that we as the licensed physician that most ATCs are working with as what we need to worry about from our standpoint, which is it's not just the liability of the ATC that we're working with, but it's also our liability. Is our company that we work with willing to take on the liability of having the athletic trainer do the reductions on field? And if so, okay, then what are the requirements that that insurance company is going to find is necessary? Such as, do you need a policy? Do you need standing orders? Is there a specific routine that needs to be followed? And then it's the comfort of the actual provider itself. Do you feel comfortable? Do you trust your ATs? I do. They're fantastic. I love them. And so, yes, I would start the conversation by using that checklist that is in the article.
I'm a fan of checklists, and you guys created a wonderful one. Can you give us a little bit more insight into what all the checklist covers? There's 4 main areas.
Yeah, so the checklist starts with a pre-reduction assessment. So while the manuscript mostly focuses on techniques for how to do the actual reduction, the truth is before you can do a reduction, you have to confirm multiple things. First, confirm it is a dislocation as opposed to a fracture. Both of them might present with deformity. So making sure that it actually is, documenting neurovascular integrity, documenting and obtaining consent, as well as considering whether or not pre-reduction radiographs and or some kind of pain medications are needed. And if you're going through that part of the pre-reduction checklist and you say, we do need x-rays. If you don't have that capability, then that's an indication to refer. So it's kind of some things like these are the things you should be thinking about before you even select what technique to use. And then the next step is selecting the technique and doing it. Once you've done it, then there's a post-reduction assessment as well. So we assess neurovascular integrity pre-reduction. We also need to assess it post-reduction so that we can document what their status was, both pre and post, and see whether if there's any deficits it was pre-existing or if it was due to the actual reduction technique. And then after that post-reduction assessment, which includes that neurovascular integrity, as well as imaging and obtaining imaging after the fact, is just post-reduction care. So what is the appropriate position to splint? What is the appropriate next steps for care?
Thank you. And I will state that everybody should go, if you even don't get a chance to read the manuscript, to look at the tables and that checklist and the figures that you guys did. It is a great way to just do an overview of the manuscript, and you'll definitely get a lot of information just from that alone. So my next question for y'all is, why even reduce on site in the first place? Why not just splint and refer?
Barb, do you want to take that one?
Sure. So there are a couple of things that we mentioned in the article that are very specific to this that we found in the research. First of all is the successful relocation rate is higher with a prompt reduction. And also, usually if you've got a patient that is in a lot of discomfort, being able to put it in fairly quickly calms them down, and then you can continue with whatever further assessment that you need to do. Like if you have a person who took a significant hit, have a shoulder dislocation, but you're also worried about a possible concussion. So both a quick or prompt reduction and then also patient comfort are two of the main things. But the other is just the psychological trauma to the patient itself. It's very scary when you get injured, and lots of things run through your head at that time. And so we always want to make sure that we put that patient comfort and that calming effect that you can get when you can reduce the pain fairly quickly.
Thank you. And you chose 3 joints primarily to focus on. Why were these 3, glenohumeral, patellofemoral, and interphalangeal, chosen?
Well, specifically with these, it was because of the frequency of occurrence. These are probably in literature the most common of the dislocations that you are going to typically see on a field of play or in a court.
In addition to being so common, also we just had lots of conversations. So oftentimes I would go and talk to Barb and Ed. I would track them down on the football sideline, and in between plays, ask them questions about this. And the more we talked about different dislocations, we would talk about an elbow and we'd be like, ooh, but there's this, but there's that. Maybe that's not a good choice. As we talked, it just kind of these three rose to the surface as the ones that my own physicians felt the most comfortable having standing orders for. So in a sense, the article is selfish because it focused on what my physicians said they were willing to do. But I think there's also that universal aspect that these are probably going to be the three that physicians are least worried about liability, about poor outcomes, about various other factors that might make them think that it's not a good choice to do a field reduction.
Thank you. So before we get into some specifics about the techniques, I want to cover any considerations for pediatric athletes that you might have.
Well, on this one, in the conversation that we had yesterday, and just looking over these questions, we wanted to clarify what we consider pediatrics, because words can be interchanged quite frequently. So for us, we were calling pediatrics or children 6 to 12 in age range. And then you've got your teenagers, adolescents who are more 13 to 18-year-olds. And just by sheer nature of our jobs, we are not around on fields of play very often or on courts for that younger age group. Mm-hmm. So most of these dislocations typically will end up in urgent care or in the ER. And so we're more addressing the older age group from 13 to 18 and above.
And some of those considerations with the adolescent pediatrics is that the techniques are very similar. The flow charts are very similar. The biggest consideration is obviously that we need parental consent, not just because these are minors. And we also considerations for fractures and open growth plates. So in the younger age group, the under 12, their bones are still a little bit more bendy. Dislocations are less common. But as they're in that adolescent range, looking at, okay, if there was enough trauma for dislocation, do we also have a concomitant fracture? And if so, is there growth plate involvement? So some people might want to be more conservative about saying, like, no, I need that pre-reduction radiograph. But then there's also arguments that, again, patient comfort, patient outcomes, the ability to get a joint in promptly does lead to moderately improved patient outcomes. So it's a balancing act between those two things. So very similar considerations as adults, just with the extra of having to obtain consent and think about growth plates.
Thank you. So what are your go-to strategies now for these three joints? Let's talk about glenohumeral joint reduction first.
For the glenohumeral joint reduction, I'll start on that one. There's a lot of different techniques out there. We don't expect that everyone knows all the techniques. What probably makes the most sense is read through a bunch of different techniques and then pick the couple that are most applicable to your own clinical practice. So for me, the external rotation technique is one. It's very simple. I know even in the middle of a lot of things going on or a chaotic situation, it's something I can do by myself. I wouldn't need an assistant. So the external rotation technique. And then if I have a repeat offender, someone who I want to teach how to manage this on their own, because they might be dislocating while myself or another medical provider isn't there, then the Voss-Holzeg matter, also known as the Davos technique, which is a self-reduction technique, is one that I want to be teaching my patients. In this research, I learned about the scapular manipulation technique. That was one I wasn't familiar with, and I'm intrigued by it. I haven't had a chance to implement it yet, but the percent success rate is phenomenal. Patient comfort while doing it, also phenomenal. So it's one that I would like to incorporate in my practice, but cannot say that I've actually done so yet.
Barb, have you utilized that technique before?
I have not. I have read about it a couple of different times, but when we actually went back and Cynthia showed me this article showing the success rate of it, I was absolutely surprised because it's not something that we commonly see as a first-line technique, especially in medical school and subsequent training since. So I was very surprised, and I'm I would love to get a patient to try it out. But for me, I have 3 techniques, and it truly depends on the environment that I'm in. So if I've got a repeat offender, just like Cynthia was stating, the BOSS technique is really great, especially that's something that you can teach a person to use, especially if they get in trouble, even when you're not around. But the external rotation maneuver is my favorite, but I have to say that it's modified for me because I, as a practitioner, have to be aware of my limitations. I'm only 5'6" and not very big. And when I'm dealing with a lineman on a football team or a basketball player that's much taller than I am, I have to find a technique that works for me, that I can rely on and modify to me. So that is one thing that I would highly recommend that you take into consideration as you learn these techniques, is that they may need to be modified for you specifically and because of the patients that you're working on in the environment that you're working in. And then the other one that I have a tendency to use is the Stimson technique, which is one that I will use if I have access to medications to help relax the patient. I've got time using that gravity. It is a great thing to use, but it's not something I would do on the sidelines. It's something that I would do back in a training room or in some modified treatment trend where I've got those resources available to me.
I'm really glad that you brought up the notion of having to take a technique and make it your own. Specifically for me, being 5'2" female, it's very difficult to do some of these. Do you have any resources, either of you, of how to find modifications of this, how to go about making that clinical practice your own?
So for me, was actually having a lot of discussions with other providers. I would have, as Cynthia said, we have a lot of sideline conversations. So talking to other providers, talking to ATs, talking to anyone who's had experience in reductions, especially when I go to meetings and they happen to have maybe a breakout seminar on reductions and fracture care, I'll ask my questions there and say, hey, does anyone have any tips and tricks that help, with this procedure or this one? And it's amazing what comes out of people and just their experience. And I highly recommend having those open conversations with people. It really makes a difference. One other thing to take into consideration just as you're learning these techniques, especially if you're working with a provider, is also finding out what techniques they're comfortable with, because it may be a great opportunity to learn a new technique that may give you better success in certain situations. So always keep an open mind on these.
Thank you. So the other joints, your go-to techniques, there's only one for Patellofemoral. Can you just give us a little brief overview of what that technique is and then move on to interphalangeal?
Yeah, sure. I'll talk a little bit about that technique and then I'll let Barb talk about some of her tips and tricks because they really help me as I, as I prepare to incorporate that technique. So that technique is applying a lateral to medial force on the dislocated patella while extending the knee. So the knee is normally in a flex position. If they've extended it already themselves, they've probably actually already self-reduced. So their knee is in a flex position. You're applying that medial or lateral to medial force while extending the knee. And as you extend that knee, you'll feel and see the reduction happen. And Barb can talk about some ways to make that easier.
So this can be a very upsetting one for a lot of people because it's not fun to see your kneecap on the side of your leg. And so I've had a lot of people yelling and screaming with this one just because it's scary to look at and they can see it typically. So having the patient actually sit up or lean against another person really helps tremendously. And especially it could be an extra pair of hands that kind of help with that lateral to medial push as you straighten out the legs, because sometimes the hamstrings and the quads contract so much that it takes both of your hands to actually pull the legs straight. So I really like having an extra person around for that technique. There's been several times when there has not been anyone else around, but I will say it's much easier with the second person.
Great. And how about interphalangeal joints?
Both of us prefer the exaggeration method. So in the literature, and there's actually some gaps in the literature, because most people, when they dislocate a finger, self-reduce, or their coach does, or their buddy does, or whoever it is. So there's actually a lack of really good study data comparing the efficacy of the two techniques, because by the time it gets to, an emergency department, which is where a lot of these studies are done, it's already been reduced. So in the literature, they talk about two techniques, the exaggeration and the traction method. And anecdotally, everyone I've talked to prefers the exaggeration method, but you just can't prove that it's the better technique. So the exaggeration technique is theorized to have less chance of a knockoff fracture when that joint comes back into position, because you're making the joints more congruent. So that's one reason why I choose the exaggeration.
Okay. Any pearls with that, Barb?
Well, there is a risk that there can be damage to the joint line with putting these back in, or there can be a fracture that occurs as you put it back in, or there was a fracture prior to it. And so I can say with this one, if you go ahead and reduce it and it will not stay in place, definitely splint this and get them in for an X-ray immediately. Don't try to re-reduce it over and over again. It's much better to just splint it as is and get them in for imaging.
I think another common misconception is people think, oh, it's just a finger, it should be easy to reduce. And many fingers are easy to reduce, but if you're having difficulty, one of the most common complications outside of fracture is actually you can get interposition of the soft tissues. For example, like the volar plate will go into that joint space. So if you're trying to reduce and you're like, this is a simple finger, why is it not going? That's one of the most common things. And if that is the case, it's not you. That person is probably going to have a surgical fix. So it's not, your technique, or if it were an ED doctor, it would have been better. It's just that there is something actually physically blocking the reduction.
And that circles us back around to a point that the paper makes, the differences between ATs and physicians trying to reduce, and how ATs one shot, right? And then refer out. Are there any other pearls or tricks to improve success that y'all have?
Well, one thing that I would say, and I would stress, is that, and it's not necessarily a pearl for, well, it is a pearl for success long-term, but the main important thing is the neurovascular. If you are looking at a dislocation that is pretty extreme, and I'm going to go outside of the scope of this article and say something like a knee or an ankle, because those are other ones that people will see. If you're looking at it and it does not look good and there is a chance of a fracture, really assessing for the neurovascular integrity. Do they have sensation in that foot? Is there a pulse to that foot? And if you think it is bad enough, then you really need to just splint it and get it over to someone with more experience, such as an ER, especially if you think there's going to be surgery involved. And don't even risk doing the dislocation. There has been a few times, I'll say in my practice and a few other physicians that I know really well, where there has been an attempt at reduction of a shoulder that also had a concomitant fracture of the humerus. And so put it back in, but it still doesn't look right. I'm just going to splint this and send this. Mm-hmm. And if, again, something just looks slightly off of what looks like a normal anterior dislocation of a shoulder, please just splint them in place and get them on an ambulance and into a full ER.
Thank you.
I think along with that thinking, one of the things I was taught, and I don't know, if this is still taught or what other AT's background is I was taught when it comes to if there is neurovascular compromise. Initially, I thought, oh, if there's neurovascular compromise, that means I'm not allowed to touch it. And one of the things we do talk about in the article is that actually that is not an absolute contraindication. So if you're noticing some sensory deficits, that actually may, I repeat, may be an indication that a field reduction is more appropriate, because you could actually reverse that neurovascular compromise by attempting a reduction. So why take the risk of an on-the-field reduction? Well, if they already have neurovascular compromise and you can reduce them and now they don't have neurovascular compromise, that actually has probably prohibited some bad patient outcomes. So it's not an absolute, it's a decision point in a decision tree. Is this a risk you're willing to take? What is the potential benefit and harm to the patient? And I think we have a flow chart of decision making for at least the shoulder in the article that helps with making that decision.
And always involve the provider in that decision process, because they're going to be the ones that are taking the risk associated with this.
Thank you both so much. What are some good resources for clinicians that are wanting to learn some more about this topic?
I think a couple of the resources you could access are referenced in the article. So the one I started with, other than obviously picking the brains of my team physicians, was Robert and Hedges' book. It is, let's see, I actually wrote down the name, Clinical Procedures in Emergency Medicine. As I talked to multiple different physicians, like, where did you start? What was your baseline? That was what they talked about. Like, this is kind of the gold standard. So that's where I started. And a lot of our recommendations are coming from that. Now, obviously, we modified them to fit AT's practice, but that's one good resource. And then there's several other articles cited within the paper that people could access, but that's where I started.
And then for me as a provider, Up to Date is one resource that we use frequently. There's several ER textbooks out that also have a lot of reduction techniques beyond what Cynthia is stating. Almost all of them have it. But for pediatric dislocations, there's a book out by Lutz von Lauer. It's Laer. Is the last name, is one book that I use quite frequently when it comes to pediatric dislocations.
I guess I would be remiss to not mention the NATA position statement is obviously a great resource for all athletic trainers as you start looking at scope and what is appropriate. So definitely start there as well.
Perfect. Thank you guys both so much. And as we wrap up, any last parting words, key take homes, if somebody wants to start implementing this today, what's their first step?
I think the first step, which was also talked about in that NATA position statement, is that you need to be able to show both the knowledge and the skills before you're doing this, so that your team physician should be actually assessing you, just like you're doing competencies as a student. That your first step is to get to the point where you could say to them, here, test me on this before you're doing these in the field. So this should not be practiced until you can document and say, I read this, I went to this seminar, something to show that you have that knowledge and skill.
Thank you. Barb?
I would agree with that. Practice, practice, practice. These don't happen very often. And so being very adept at whatever techniques that you happen to use, and I would keep it to maybe one or two, and that's it, are really helpful, because you're going to be in a pressure situation, and it's good to be very familiar with the technique that you have chosen for that reduction.
Perfect. Thank you guys again so much. Dr. Wright, Dr. Brandon, we really appreciate you taking your time to talk with me today. And just a reminder to everyone out there that this material, as well as all of the Journal of Athletic Training's material, is available open access on our website. Thank you guys again.
Thank you.
Thank you.